Well, good morning, everyone, and welcome to today's Surgical Grand Round. It's a great pleasure to introduce two distinguished speakers today. Our first speaker is Satheesh Prabhu, who's a consultant oral and maxillofacial surgeon here in Oxford and also an honorary consultant at the Royal Berkshire Hospital in Reading. He trained in Northwest Deanery with subspecialty fellowships in Birmingham and Manchester. He has subspecialty interests in head and neck cancer and orofacial reconstruction. He's a recipient of a Leibinger Fellowship from the European Association of Oral and Maxillofacial Surgeons and an award from the International Association of Maxillofacial Surgeons. Our second speaker is Kunmi Fasanmade, who's qualified at Guy's, King's and St Thomas's Hospital and undertook his specialist surgical training in the Southwest Deanery. He became an oral maxillofacial surgeon in Oxford as a consultant in 2010. And has a special interest in head and neck cancer, including management of benign and dysplastic mouth lesions and facial trauma. Kunmi was also clinical lead in maxillofacial surgery at Buckinghamshire Hospital, where he steered the unit through the COVID-19 pandemic. I welcome them both. What I'll do is allow them both to speak, and then we'll take some questions at the end. There may be a brief interlude in the middle while we switch from one computer to another. But if everyone just remembers, during the talk, please keep microphones and videos off. And at the end, hopefully people will be able to ask questions themselves by putting a hand up, and we'll be able to let you speak. If that doesn't work, then put your question in the chat and we will read it for you. Thank you very much and welcome.
Thank you, Professor Fitzgerald. It is indeed a pleasure and honor to stand here and share our experience. The reason we have chosen this topic, the bone reconstruction in head and neck cancer, is because we provide the highest number of bone reconstruction in the trust and also nationally are one of the busiest units. Before I go to the talk, I prefer to share my surgeon-level data, just gives you the flavor of the workload that we have. And even though it is 2022, sort of a cutoff point, we have only become more busier. So that's the sort of numbers just to sort of give you an idea of our workload. And something about the oral cancer, there's some statistics for the junior colleagues who may not have got much information. It is indeed a cancer that kills more number of patients than cervical and testicular cancer combined. And we see about 200 to 250 new cases in Oxford, which we treat. And more than that, we see patients who are not treatable as well. So it's a fairly large population that we cater to. What you might be worried about is the bottom right-hand corner. The awareness about it is very limited, not just among patients, but among the clinicians as well. And the reflection of it is that we got 50% of cases that are presenting to us are still diagnosed in late stages, which means a visible cavity of the body that we all should be examining and monitoring, we are failing to do. So it is something that I feel this talk should hopefully will help to an extent to raise about oral and maxillofacial surgery and more importantly on oral cancer. So why do we resect bone in head and neck cancer? My apologies to all the senior colleagues who might find this information repeat, but I'm hoping that the junior colleagues will find it useful. So the reason we resect bone is mainly sort of twofold. It is part of the resection of the oral cavity cancer. For example, if you look at this picture in the middle, what you got is a mandible and the part of the tongue that has been resected. Underneath the tongue, what you see, the growth is essentially the cancer, which is fairly extensive, and it goes up to the lingual aspect of the mandible. To get a clear margin, we not only have to resect the tongue, but we also end up resecting part of the mandible. And apologies for my dirty finger there. The one unique thing about maxilla and mandible is that it is a mesenchymal structure, but it has got ectodermal structures embedded in it, that is teeth. So which means you can develop carcinoma within the mandible as well. Normally, you don't see carcinomas. Usually, you see sarcomas if it's a primary tumor of the mandible. So if you have these two, maxilla and mandible, in the head and neck regions, you're likely to see carcinomas originating primarily within the bone. What can present sometimes as a gum disease to dentists can actually be a cancer within the mandible. What you see here is a fairly extensive destruction of the mandible on the left-hand side, and there is a pathological fracture as well, which means we have to resect this cancer, which will leave a fairly large defect in the mandible. So we resect it through the neck, and as you can see, once the resection has been completed, there is a fairly large communication between oral cavity and the neck, which is not compatible with life. We need to separate the oral cavity from the neck, and hence we need to do the resection and followed by reconstruction at the same stage. We cannot do it like, for example, breast reconstruction, where you can delay the reconstruction on a later date. So that means it's a fairly large operation that extends to 12, 14 hours at a stretch, and we got a great team, and we do that almost day in, day out. So why do we need to reconstruct bone? Obviously, I did say that separating the oral cavity to neck is quite important. And the other element to it is to maintain form and function, to separate oral cavity, as we've seen. And then, of course, if it is a maxillary cancer, we need to separate oral cavity from the nasal cavity. So they are the sort of basic reasons we do reconstruction. So what are the options to reconstruct maxilla and mandible? Mainly, there are three sort of bony reconstructive options. One is scapular. We use the lateral border of the scapula, as you can see it on the top left-hand side. And a segment of the lateral border is used, and that we usually plan it virtually to start with. Sometimes we do it freehand, but with the help of a 3D model printed beforehand. And the skin paddle covers the intraoral defect, and the bone is replaced as per, bone-to-bone replacement, and then the wound heals. Similarly, the alternative is a deep circumflex iliac artery-based flap, or DCIA as we call it, a good segment of bone that comes with it, which is quite useful if you're planning to rehabilitate the patients with dental implants. You need a good stock of bone, and the DCIA-free flaps gives a good volume of bone. The muscle, the internal oblique that's been harvested, along with the bone, what you can see in the middle, is the one that lines the oral cavity. Then the third option, fibula, which is a bone that we quite frequently use it. And my colleague, Mr. Kunmi Fasanmade, is going to talk to you about that shortly when I finish my presentation in the next 20 minutes. What we have here is the three options. Then how we do this? We usually, what we call a free tissue transfer. That means we separate the tissue from one part of the body and transfer it and connect it to the blood vessels. So what you see here is a angle of the scapula on the top left-hand side. We are harvesting the tissue with artery and vein. And the one that is sort of running the facial artery is the one that will donate the blood to the free tissue that we are transferring. And the internal jugular vein on the top right-hand side is where the vein will be connected to. And this is done under the microscope. What you can see in that video is where the facial arteries are sutured using a 10-0 suture. And once it is connected to the artery and vein, that's what it looks like on the bottom right-hand side. And this is the what we call the free tissue transfer. And once we have achieved and the wound has healed, this is what it looks. What we have done here is to reconstruct the mandible using fibula and scapula to maintain form. To maintain function, we need to achieve dental implants into this bone so that they can have appropriate function. A young gentleman like this can't go around without teeth, and that's what we have done here, to place implants and maintain form and function. Maxillary reconstruction, similar sort of concept, slightly more challenging because the blood vessels are quite far from the reconstruction site, so you need a longer pedicle for this. What you see here is in the top left-hand side an SCC of the edentulous maxilla that's been resected, which means a fairly large communication between oral cavity and nasal cavity that needs to be separated. We have used a DCIA flap to reconstruct the maxilla. Bottom left-hand side, again, a maxillary defect, but I've used a scapular tip to reconstruct it. Deep circumflex iliac artery-based free flap, what we call the DCI, is the sort of the first flap that I'm going to explain and how we do it. The anatomy is quite slightly complex, but quite easy to harvest in many ways. You have a good stock of bone. We use the internal oblique. We got the internal oblique that has got the ascending branch, which we identify and then reach to the deep circumflex artery. Artery and vein both are will be harvested, and then you close the transversalis and the external oblique. So it will be a small defect in the internal oblique which you harvest. You can either reconstruct that using a mesh, or we just tend to leave it open as well. But it does leave a slight weakness in the abdominal wall. Not great if they have a fairly large body habitus. The stock of bone that you can see here is measured beforehand, and we get a cutting jigs or props that we can use to harvest the bone of the appropriate shape and size. So the external oblique has been retracted on the left-hand side. So the one in the middle shows the internal oblique that's been reflected, and you see the ascending branch. That will take us to the deep circumflex iliac artery. And then we use the cutting jig to measure the bone that is needed of the right shape. And then the deep circumflex artery and vein are dissected all the way. Longer the pedicle, safer it is to connect in the neck. And then the stock of bone goes into the planned position, and we use the titanium plates to hold it in place. Here is a SCC of the right retromolar area. This gentleman had jumped off the first floor in his teenage years, and he had fracture of the fibula and calcaneum, which means we couldn't use fibula to reconstruct. So we used the DCIA, and the internal oblique becomes a well-mucosalized tissue following the reconstruction, and that is the donor site morbidity. This is about day 10 or so. What you see is that it's a fairly large incision, and it's going out of favor for two reasons. One, the morbidity is slightly more than the other bony flaps, and two, it's an unsightly scar, especially for a young woman or for men for that matter. It's not great to have a large scar in the abdominal wall when we have the option of alternatives. The next free flap that I would like to discuss is the subscapular system-based osteocutaneous flap, or the scapular free flap. When I started as a consultant 11 years ago, I used to do more fibulas and less number of scapulars, but I think I can safely say that it has now sort of reversed. I do more scapulars now and less fibulas. It's just a choice for a few reasons, which I will go through in a minute. So this is the anatomy of the scapular free flap. What you see here is the left scapula. You have the circumflex artery and the transverse cutaneous branch that provides the blood supply to the cutaneous part of the flap. Then you have the periosteal branch that supplies the bone, and the circumflex artery that connects to the subscapular system is the pedicle. If you want more tissue, we can harvest a latissimus dorsi along with it. So if good Lord tells me you can only use one free flap for the rest of your career, then I will be very keen to choose this option of subscapular system reconstruction. I'm fairly confident to fill any of the defects that needs to be reconstructed in head and neck. So it's a very versatile anatomical area to harvest free flaps. There are various various sort of options that we use. Osteocutaneous, the run-of-the-mill on the top. Then you can also have the bipedal flap, or if you want to have a large muscle, then we can harvest thoracodorsal-based latissimus dorsi. And if a piece of bone is needed, then we harvest the scapular tip along with it on the angular branch. So there are multiple options there for us to use. One of the main drawbacks, or seen as a drawback, is the positioning of the patient, which means if we are doing a neck dissection and resection of the tumor, we need to do that in supine position, and following that, we need to turn the patient, then harvest the scapular free flap, then turn the patient back supine, and then insert the flap and do the microvascular anastomosis. So that is the seen as a major sort of downside to scapula, but we still finish within sort of 12, 14 hours time the whole process. We have also come up with this technique of positioning the patient supine in an appropriate, select patients where the BMI is low, and if the cancer is on the right side and if you're harvesting the scapula on the left, we can position the patient in such a way that two teams can operate simultaneously, as you can see in the bottom right-hand side. The access is reasonably good, And also if the BMI is adequate, less than, if it's an average BMI, then we can manage it. So that's what we sort of come up with, the technique of placing the patient supine. The technique is, once you start doing it, to become more and more, and we have evolved over the last 10, 11 years. So you Doppler the triangular space for the cutaneous branch that supplies the skin paddle. You identify the fibers of the latissimus dorsi and teres major. They both run in similar direction, but latissimus dorsi doesn't attach to the tip of the scapula, but teres major does. Once you have identified the teres major, you try and divide it, which gives you access to the circumflex vessels and to the axilla. We harvest a paddle of skin and dissect it all the way and then we identify the segment of bone that is needed. What you see here is the subscapular system. The thoracodorsal artery is on the, where my arrow is. I think people who are on the online version might be able to see my arrow. So that's where the thoracodorsal artery joins the subcircumflex, making a subscapular system, the top end of the slide on the right-hand side. Once you have identified these soft tissue, then we take a segment of bone. On the right-hand side, you will see a segment of bone underneath it, which has been sort of separated from the scapula. It's the lateral border of the scapula that we have harvested here. Then we suture the teres major back together, and that is to sort of maintain the function. So a first case is a maxillary reconstruction for a osteosarcoma, the Sunday classic appearance on there. And that has been resected. It's a fairly large resection, includes the skin, maxilla, and the soft tissue in the palate. So that's a three-dimensional resection. We've harvested the skin paddle along with the lateral border of the scapula here, and that skin paddle becomes the cheek. We are Dopplering to make sure that the blood supply is intact at the end of the procedure. And that's the stock of bone that we get. And this gentleman had his rehabilitation, and that's him 5 years post-surgery. You can see that the donor site morbidity is quite limited. He is a builder. The second case is a case where fibula was not possible, peroneus magna, where you only have 2 vessels in the leg, or sometimes even 1, can be a contraindication to harvest fibula free flap. So there is no peroneal vessel on its own. It becomes fused with the posterior tibialis. So what we have done in this case was to harvest the scapula for this young gentleman who had a fairly large tumor. In fact, we have Kunmi, myself, and a couple of our colleagues, we've published the sort of anatomy of the vasculature of the lower leg. It's about 5% prevalence, the peroneus magna, which is quite a high number. So we always do the angiogram before harvesting fibula. So this is the case where we did the first scapula, but unfortunately following radiotherapy, it developed osteoradionecrosis, not that common. So we had to reconstruct using the other side of the scapula after about 4 years. He's a young gentleman. He had 2 kids after his first diagnosis of cancer. Still going very well. He needed a bony reconstruction because if the plate and soft tissue won't last for long, it will fracture at some point. So that's the second scapula that's gone in there. And just to sort of give you the form and function and the donor site morbidity, his mouth opening and his ability to bite food is what you can see there. And the donor site 6 months post-surgery, and he's 5 years since his initial surgery and radiotherapy. A fairly large skin cancer that needed to be resected and reconstructed. Again, a scapula has been used here. We have come up with a new technique that we are publishing now, where rather than dividing the teres major, we are maintaining the integrity of it so that the function is maintained better. Generally, 3 to 6 months down the line, the function is considered as almost back to normal in the literature, and our experiences has been the same. So what we've done here is the teres major has been retracted, and the segment of bone that is needed, usually 6-7 centimeters, is easily accessible. The bottom right-hand side, what you see here is the access to harvest the bone. So in the past, we used to divide the teres major, as you can see there. But now we maintain the teres major so that the function is even better maintained. So this is the post-op 4 weeks down the line. And that is 8 weeks. And that is 4 months post-surgery. One of the benefits of the scapular free flap is that the donor site is primary closure. When you have free flaps where we have to graft skin to the donor site, like as in fibula or a radial forearm free flap, which are quite far from the heart, the healing potential is quite limited, so it takes longer. If patient needs chemotherapy as part of the oncologic management, and if they have a healing wound, it's not a great idea. So one advantage with scapula is that it's a primary closure and the scar is well hidden in the armpit, which makes it quite attractive to patients when you give them the option. Virtual planning is quite a useful tool. You can measure the bone that is needed and the shape of it, and you get cutting guides to angulate your saw when you're harvesting the bone. My colleague, Mr. Fasanmade, will tell you more, who's got more experience in that field. What we have now found is that a single segment of scapula can be managed without having to do virtual planning. We use a 3D model, we mark the resection on it, and then bend the plate, and then the defect is measured and then harvested freehand. The cost of a virtual planning is about £5,000, and a freehand, a single segment scapula has a good contour that fits very well. And after doing a few of these, we felt it's not a best use of money. So we have gone freehand. But if it's an anterior mandible where we use fibula, we do use virtual planning in those cases. Another case of virtual planning for scapular reconstruction. But if it is a complex reconstruction, say, for example, if it's an edentulous mandible that needs anterior aspect of the mandible to reconstruct, so then it is much useful to have the virtual planning to reconstruct in a shape that is needed. So one more sort of case where we harvested the scapular tip with latissimus dorsi to reconstruct the subtotal glossectomy and the segmental resection of the mandible. So just to say that it's a big team. These are my consultant colleagues that I work with. Mr. Selbong is my sort of operating buddy. We see each other more than our wives, I think. And I've got other colleagues here. Kunmi, you will be able to hear him in a minute. Mr. Gerg, Mrs. Greystone, and our new colleague, Mr. Rajat Paul. It's a big team, and also I would like to thank the speech and language therapists, the dietitians, and my staff nurses on the ward who look after these patients for 2-3 weeks in a very complex atmosphere. With that, I'll pass the word to my colleague, Mr. Kunmi Fasanmade.
Thank you very much, Satheesh. I'm very grateful for the opportunity to be able to address the forum again. Myself and Mrs. Greystone addressed the forum, I think, in 2015 on similar topics that have been advanced since. So thanks to the audience, thanks Satheesh for an excellent presentation, really setting the scene. My job is a bit easier now because most of the foundational things that have needed to be set up and discussed has already gone through, so hopefully I should be able to whiz through my aspects. And also to thank Professor Fitzgerald for hosting this morning. Thank you very much. So I can probably just start talking about the fibula free flap reconstruction. The very first one we did was, the fibula has been going on for many years, certainly since the late 1980s, 1990s. The very first free flap we discovered when the Iron Curtains came down, and we saw that the Chinese were already doing what they call the Chinese flap, which is a soft tissue flap only. But that technology or that aspect of surgery has evolved since then. We've actually done more in the way of different flaps, and you've had a very good summary about the different bony flaps. that is available to us as reconstructive surgeons. And of the 3 main flaps, including there's actually sometimes historically the radial forearm free flap with bone, which we realize is actually not a good idea because people tend to fracture their forearms afterwards, and you need heavy plates to reinforce the forearm. We're settled on 3 flaps, and more so now two bony flaps for bone reconstruction, and that's the scapula. And you've had a very good summary about the scapular free flap by my colleague, Mr. Prabhu, and I will be today talking to you about the fibular free flap, which is a versatile free flap in that regard. And the very first, and we have since, so the bits I'll be able to sort of whiz through would be this aspects. This work is, as Mr. Prabhu mentioned earlier on, entirely rooted in an MDT. You cannot do this alone. And in that picture there, you can see, I mean, this is a very outdated photograph. Apologies. I'm still trying to organize a group one. But you can see Satheesh Prabhu at the very back there, myself in the corner, and Mrs. Greystone is also in there, just across that way. We've had 2 fantastic new colleagues, Mr. Garg, who is now 5 years into his role, and we have got a gentleman called Mr. Paul, who's working with us now. And not to forget the wider MDT, which is, of course, plastics, ENT, the oncologists, specialist nurses, dietitians. But as my colleague has mentioned, I think the remit of bony reconstruction will fall to the oral and maxillofacial head and neck surgeon, because by virtue of having to tackle the jaw, you would be the person who would have the need to be able to reconstruct the bones in the face and jaws extensively. A wide area, we cover about 2.5 million, 450 new patients per year, and we cover those regions as part of the Bob ICS. Milton Keynes is going to gradually probably come into our remit. This is a nasty disease continuing to increase yearly. In 2011, there were about 8,000 cases. It's now above 11,000 and continues to increase. Actually, a disease that's prevalent in all age groups, and we're noticing that the younger age group is actually increasing as well. Not sure as to why that is, and I'm sure there will be a need for more sort of demographics and epidemiology to try and work out what the causes for that could be. We know that human papillomavirus is probably contributing to oropharyngeal disease, but oral cancer is not as predictable. Risk factors, which have been gone through before. And this sort of defect, we can reconstruct that, we can resect that. And I think after resection, you then engage with reconstruction, but always remember that there is a limit to what we do. This is not resectable. You will not get clay margins, and whatever complex reconstruction you do here is potentially futile. And sadly, this gentleman had to undergo palliative care and didn't survive. Staging processes before we engage with this, and part of that would be assessment for vascularity, as we mentioned earlier on before. Majority of oral cancer would be treated with primary surgery and sometimes adjuvant radiotherapy. And for bone, for some soft tissue lesions like soft palate, you couldn't actually give them radiotherapy, primary radiotherapy as your treatment option. But important to mention and to remember that for bony reconstruction, you have to carry out surgery. If you do not resect the bone, there will be some shielding of cancer cells, and you would end up with recurrences. We do about 70 microvascular reconstructions per year, of which 15 are reconstructions for the mandible and maxilla, which would mean reconstructions using bony flaps. So that's the sort of volume that we do. And the preferred flap, in terms of volume, would probably still be tilting towards the fibular free flap. We had Fuchun Wei, who is one of the masters in head and neck reconstruction, and he gave a talk here many years back, which I attended, and in their unit they do about 700, they've done about 700 fibulas at the time of presentation, and he mentioned that the workhorse for mandibular reconstruction would be the fibula. But we also have the scapula, and in the unit, our unit is a high volume and a high quality and high functioning unit, and it's good to have all the remit of reconstructions within the service, so that we carry out DCIAs, we carry out scapulars, and we do have a very high quality fibular reconstruction. So mandibular and maxillary reconstructions, we go through the reconstructive ladder, and some of it would be the need to divide the mandible to gain access to things like the spine, sometimes oropharyngeal disease. You might need to do a lip-slip mandibulotomy, and simply putting the mandible together and putting a couple of plates on that is all that you probably need. But when you're actually having to resect segments of the jaw, substantial segments of the jaw, there will be the need for extensive reconstruction. And the place for pedicle flaps, things like pec majors, is not really as robust in the reconstruction of the head and neck. That's been discussed. We've discussed the scapula as well. And the fibula, we have briefly mentioned the anatomy of that, and it's really to understand that, and all of us will know this with a very strong knowledge of anatomy. Your femoral artery goes through the Hunter's canal, comes out into the popliteal fossa to become the popliteal artery, and immediately drops off a branch which goes through the interosseous membrane, which is one of our landmarks when you're raising the fibular free flap into the anterior compartment to become the anterior tibial artery. The two distal branches of the popliteal artery would develop into your peroneal artery and your posterior tibial artery. This flap is based on the peroneal artery, and if you end up with a dominant peroneal artery and a rudimentary posterior tibial artery, you really do not want to raise one of these. And historically, there have been cases where there have been tissue loss in the foot when people haven't checked these. So it's imperative to carry out a CT angiogram. It's imperative to carry out either CT angiogram or magnetic resonance angiogram. The CT angiograms is probably better because you can then use the same CT for your virtual plan. And here we are. The other advantages of this flap is the length that you can get. You can get up to 26 centimeters of this bone, which means if you needed to reconstruct from the mandible on one side, the condyle on one side to the other side, which can sometimes occur, and also not to limit this to cancer, sometimes in trauma, you could end up with gunshot injuries where you do have extensive bone loss. This bone will help you. This will give you the length you need. It's got a good bone stock as well, and it is with the ability, because of the length of it, you can actually shape it probably a bit more precisely. You can get two skin paddles onto this as well. So this is a case where we've had an intraoral defect and an extraoral defect. This is not a case of mine, but I have actually got one of my cases that I will display. In the good old days, we sat at a desk and after the bone has been taken out, as you saw, and then we'll, on the bench, try and shape it, cut it into bits, and try and model it into the jawbone. You also have to bend one of these plates into the mandible. The mandible might be diseased. You might not be able to get right under the periosteum near where the disease is. So you actually have to be very creative in how you're fashioning that plate. Whereas now, the virtual plan, which is effectively the way things are going and the way things should go. I've got most people in this room and most people online will probably not know of this cartoon character called Andy Gump. But it was effectively based on the fact that this chap doesn't have a mandible, and he was quite a comical character. But actually, in reality, we do have people who had these sort of defects, who would have their jaws resected for cancer or for trauma or for infection, and will have no reconstruction. And this is called an Andy Gump deformity after the cartoon character. The story of this picture goes that this chap who actually, apparently there was some contest between this guy, David Hogg, who said that he felt that the cartoon character was fashioned after him and wanted some royalties. But you can imagine he didn't win that legal battle. But actually, more close to realities here is this gentleman here with a mandible. This is a stock image of someone, again, who does not have a mandible. And you can imagine how disabling this is. This chap also will find it very difficult to maintain his saliva, moisture control whilst talking. speech will be significantly affected. And you can see here where we also have, this is an amyloblastoma. It's not actually a cancer, and some of these could be treated by decompression. But this is a solid one. I encountered this young lady when I went to the Gambia to do some medical relief work, and you would have to resect her jaw from the molar on one side to the other side, and you need a good stock of bone to be able to reconstruct that. Unfortunately, because of the facilities we had, we couldn't help her, but we were able to send her across to Kumasi, which is a big unit in Ghana where she would be able to receive care. And here's someone who had a suboptimal reconstruction before. You can see the defects she had, and secondary reconstruction with good projection. So now, to counteract the problem of having to cut the plate on the bench, came across this in 2013, a course I went to in Hamburg, Eppendorf, where we were given models, and we went through how they do their surgical planning. And shortly after that, I came to Oxford and did a pilot case in 2014. This was the very first case done in Oxford by virtual planning. And it was a simple anterior resection. I kept it very simple because it was a pilot case. 3 segments of the fibula. You don't want any of the segments to be less than 2.5 millimeters, otherwise you will lose that bony segment. And here is the sort of, this is the sort of, and she's saying the red fox jumped over the fence. Speech is fantastic. You can see her facial profile is brilliant. Now, there are demerits to the virtual planning. And one of them my colleague mentioned earlier is the cost. Okay, so £5,000, exactly. Now, the one thing to say about the £5,000 is with patient-specific implants, there is a national fund which does not come out of the budget for that particular case, which will be given to the trusts. And also, if you remember that we had those plates I showed you earlier, the bulky plates, each of those plates costs about £1,500. And sometimes while you're trying to bend those plates, which takes about the whole process of ischemic time in theater, trying to bend plates and fashion the bone can take up to 3 hours. If you put all that money together of plates that you might discard because they haven't been bent properly, and the theater time that you're sat with no activity and the extensions of your theater slots, you probably would have made that money back. It creates ease, and when you can see here, it's all very precise. Surgical margins, we've looked at our data, precise. There's been no difference between what you're going to resect for cancer margins and the virtual plan. And you can then extend this fibula with a condylar component if you're resecting the condyle. I think at this point I'll mention that all my condylar resection patients unfortunately have died. And that's probably telling you something, that if cancer has extended to the condyle, perhaps you might not win that case. But in trauma, gunshot injuries, to be aware of that level of precision, and you would agree that that is very precise. Here is a complex defect. This resection is, at the front you can see the mandible, the cut end of it, and at the top is the maxilla and all the soft tissue in between. So you can imagine that that would be a very disabling defect if not reconstructed. Here we're looking at lateral defects, and a lateral defect, again, virtually planned. All the screws that come in here are exactly where you want them. So it's effectively like Meccano once the cancer is resected. And you can actually get, because you're mirror imaging the contralateral side of the mandible, and you flip it to actually reconstruct the side you're having to tackle, there is no residual defects. Here is the fibular segments and showing the vascularity. And these pieces are effectively made out of reinforced polystyrene plastics. One of the downsides of using these is that these are very bulky pieces, and you have to do a lot more periosteal stripping to be able to put it on. But you can actually replace these, not for very much at all, with titanium, which is much easier, doesn't distort. The reason why they have to be that bulky is when you're making a cut, you don't want to distort and you can see here that the screws are fitted exactly to where the reconstruction will be sitting in the jawbone. Here's one with the jigs applied. That jig is about to be applied, rather. This is it applied. The cut is made. That's the posterior cut. And an anterior cut had already been made as well. Here's the fibula with the jig is applied to that. That's cut as well. And the whole thing will remain rigid until this jig comes off, and then it will collapse until you then reattach your plate. So here we go, and then you put your plate on. Do note, whilst the plate is on, this is still connected to your recipient blood supply in the leg. You can park this, wait for the top end resection. As Mr. Prabhu, my colleague, mentioned, there are 2 surgeons carrying this out, 2 consultants with a supportive team. And you go off, you get lunch, whatever it is, and you come back when they're ready for the reconstruction to come up. You then detach that segment, and that segment slots exactly into the jawbone. That can then be followed by dental rehabilitation. We work with very good colleagues in restorative dentistry who would help us with things like implants, but usually they like to start with some partial dentures initially, as you can see here, and here's a very good outcome. And here's a combined intraoral and extraoral defect, and the lip has just been planted onto a de-epithelialized aspect of the fibular free flap. And here is a very happy patient. This was a sarcoma patient. And the picture you saw earlier on where the lady was saying the red fox jumped over the fence, this is the same person, highly functional, and to credit to the wider team, she had her ovaries frozen, and here she is with her new offspring. Because often with sarcoma, people have to undergo chemotherapy at some point along the way. Here is a maxillary defect, and it's important to mention, whilst we're talking about this, this is actually all the way from the front end, and this has gone into the nasopharynx, and right behind us there will be the skull base. So you can use these same approaches for reconstruction of composite units that might involve the skull base, but of course, working with your neurosurgical team and the skull base team. And that plate you can see here is actually the beginning of an orbital plate, which you can see in the lower left quadrant there. You can see the top end of the plate just shining through. That gives you suspension of the orbital contents, and then the fibular free flap goes in. And this is a similar case to the one I highlighted, but of course on the contralateral side, just to show, I didn't get pictures of that other patient post-op, but just to show you how the fibula looks to be sat in there very nicely, and the defect on her face is only very subtle, just underneath the eyelid, without any evidence of ectropion. And here's her wearing her glasses. You can hardly notice. The symmetry is extremely good compared to what she would have had before with an obturator. And here's another young patient, sarcoma patient of mine, who had a maxillary resection and reconstruction using a fibular free flap. She's a dental student and has gone on to resume her dental studies. I think one thing that's important is the need for robust postoperative support for any of these flaps we've talked about. And I think that's the clincher with the fibula. If you've got people who, good physiotherapies and good postoperative support, you get very good outcomes. I would say if they weren't going to win the London Marathon before they had a fibula, they won't win it after they've had one. But in terms of daily function, in terms of mobility, running, whatever it is, there is no defects that we've noticed over these number of years, and not significantly recorded with the fibula. People get on and do most things, in fact, not everything they did, particularly everything they did before the operation. There were no cases of resultant functional dysmobility, and very good input from the restorative dentistry team. Mr. Paul Wilson and Mr. Raj Verdi, whom we work with here, will give you good outcomes. And here's another one, a maxillary resection, and he has had his teeth in. And now I'm going to quickly mention, I've got 2 minutes to quickly mention about further advances. So we have advanced. We are now saving ourselves from 3 hours to about 55 minutes ischemic time, which is the time when you disconnect the flap and have it completely reconnected with your artery. But is there more that we can do? Are there further advances that we can do in this field? The answer is an emphatic yes. And we've mentioned about the mandibular recontouring. So we often, if you notice all the pictures we showed you, puts the bone at the low board of the mandible such that you've gone for the patient's facial profile over the location of the bone. And often it's very difficult actually for the restorative dentist to get down to that bit of bone because it's right down on the low board of the mandible. And one thing that I have tried to do, and I've again started with benign disease, but there is scope for this to be extended into cancer, is to move the fibular or scapular unit to the top end of the alveolar ridge because the bone isn't wide enough. None of them will be exactly as wide as the mandible originally. And by so doing, you can see in this model picture here, you end up with a defect on the low board of the mandible. People have tried to double barrel the fibular free flap, and you can actually do. It becomes like a nunchuck, and you roll it on itself. If you make the cut too precise, you would kink the vessel, and people would end up with bone death of the distal segment. But if you take a bit of the bone away and you fold it back on itself like a nunchuck, you actually can have a double barrel fibula, which works really well. However, complexity, I think, can introduce difficulties. Whereas this is a polyether ketone, which is a material that's now being used for craniotomy and cranioplasties. And it can easily, it's like a bone, it will mirror bone. It doesn't integrate. Instead undergoes pseudo-integration because you get a fibrous band that holds it up against the jawbone. And you can see here, this is a young patient and another one with precise reconstruction of the lower border and good outcomes. First case, I said, 2014, 46 cases since then. Most of these cases are done for squamous cell carcinoma. 37 of these have been, around about 37 or 41 when I wrote this slide, but we've done another 5 or 6 since. 37 are mandibles and 4 maxillas. Failure rate, minimal, and our figures are much above national average in that regard. We've had a 1.2% partial loss. Allow time for planning, keep it simple, avoid complex designs. Thank you very much.
Thank you very much, gentlemen, for these wonderful talks.